A simple puncture wound can become life-threatening within days if managed incorrectly. This is a high-yield MRCP topic and essential for clinical practice. This summary is based on the latest UK Green Book 2025 recommendations on tetanus post-exposure management. Tetanus management depends on two key factors: wound type and vaccination history. The aim is to prevent toxin production by Clostridium tetani using either vaccination for active immunity or tetanus immunoglobulin for passive immunity. Step 1. Assess the wound. Clean wounds are non-penetrating, less than 6 hours old, and have negligible tissue damage. Tetanus-prone wounds include puncture injuries, especially with soil contamination, wounds containing foreign bodies, compound fractures, animal bites or scratches from soil-exposed animals, and wounds associated with systemic sepsis. High-risk tetanus-prone wounds include wounds with heavy contamination, such as soil or manure, extensive devitalized tissue, burns, or surgical intervention delayed for more than 6 hours. Step 2. Clean the wound. All wounds must be cleaned thoroughly and debrided when needed. Do not delay because the incubation period can be short. Step 3. Know when to use tetanus immunoglobulin. It provides immediate passive protection. The prophylactic dose is 250 international units intramuscularly. Increase to 500 international units if the injury is more than 24 hours old, heavily contaminated, or associated with burns. If both vaccine and immunoglobulin are required, give them at different anatomical sites. Now the most important MRCP part, the exam scenarios. Scenario 1. Fully immunized, with last dose within 10 years. Clean wound, no treatment required. Tetanus-prone wound, no treatment required. High-risk tetanus-prone wound, no treatment required. Key point: fully immunized within 10 years means no immediate treatment, regardless of wound severity. Scenario 2. Adequate priming but last dose more than 10 years ago. Clean wound. No treatment required. Tetanus-prone wound. Give an immediate reinforcing vaccine dose. High-risk tetanus-prone wound. Give an immediate reinforcing vaccine dose plus 1 dose of intramuscular tetanus immunoglobulin at a different site. Key point: if the wound is tetanus-prone, give a booster. If it is high risk, add immunoglobulin. Scenario 3. Incomplete vaccination, unknown vaccination status, or born before 1961. Clean wound. Give an immediate reinforcing vaccine dose. Tetanus-prone wound. Give an immediate reinforcing vaccine dose plus 1 dose of intramuscular tetanus immunoglobulin at a different site. High-risk tetanus-prone wound. Give an immediate reinforcing vaccine dose plus 1 dose of intramuscular tetanus immunoglobulin at a different site. Key point: if vaccination status is incomplete or uncertain, give vaccine. If the wound is tetanus-prone, add immunoglobulin. Special groups. Severely immunosuppressed patients may not be adequately protected even if vaccinated. They may need both vaccine and immunoglobulin after exposure. People who inject drugs are higher risk. Give a booster if there is any doubt about their vaccination status. Do not use point-of-care antibody testing for acute wound assessment. Rely on vaccination records. Final MRCP takeaway. Fully immunized within 10 years, no treatment. Last dose more than 10 years ago, booster for tetanus-prone wounds, booster plus immunoglobulin for high-risk wounds. Incomplete or unknown vaccination status, vaccine for clean wounds, vaccine plus immunoglobulin for tetanus-prone or high-risk wounds.